Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as a digital partner for this event, and the focus of today's session is pediatric anesthesia. Now, I would like to invite Dr. Meenakshi Sundaram sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former National Vice President of the Indian Society of Anesthesiologists and has held key positions including Governing Council member, President, and State Secretary of the ISA Tamil Nadu State Branch. To proceed with the session, over to you, sir. Thank you.
Thank you very much. I request our City Branch President, Dr. Munian, to deliver his address.
Good evening, all. On behalf of ISA Puthukkottai City Branch, I welcome the moderator and our academic chairman, Dr. A. Sundaram sir, and faculties and delegates for the online webinar. Today, we are conducting 30th episode of second edition of Puthukkottai Bhudhan. Today, we are going to talk about the pediatric anesthesia and its management. Pediatric anesthesia and its management is a unique field that requires deep understanding of the anatomical and physiological characteristics in pediatric children. What are the key considerations regarding pediatric anesthesia? Age and size. Pediatric patients range from premature infants to adolescents, each with a distinct physiological and anatomical characteristics. Airway management, pediatric airway management is it's a complex and delicate, requiring specialized equipments and its specialized techniques. Fluid management, children have a higher surface area to volume ratio, making them more susceptible to fluid shifts and degradations. Temperature regulations. Pediatric patients are more prone to hypothermia because of their large surface area to their weight. And pre-anesthetic considerations, the routine perioperative assessment like complete blood count, ECG in some patients to needed echo to rule out congenital heart disease. And anesthesia techniques, we are more often used with inhalation anesthetists due to their pediatric patients, due to their fear of needles and difficulty in IV line assessment. Anyway, we should give the IV line before induction of anesthesia. And total intravenous anesthesia is another one, which it is often engaged in patients where general inhalation anesthesia is not indicated. Regional anesthesia can also be indicated in supplemented with general anesthesia in view of pain relief. And the monitoring of the pediatric patients. Standard monitoring, it includes ECG, pulse oximetry, capnography in case of GA, and blood pressure monitoring. Temperature regulation is much more important in pediatric patients. It is essential to prevent hypothermia. Fluid warming, it is important to prevent the hypothermia and maintain fluid balances. Challenges and opportunity in pediatric anesthesia. Pediatric anesthesia workforce, there is a need for more pediatric anesthesiologists, especially in the low resource settings like our Puthukkottai. Research and innovation, continued research and innovation are necessary to improve the pediatric anesthesia care and outcomes. Conclusions, pediatric anesthesia patient requires comprehensive understanding of the unique needs of children. Our speakers are interested to share their experience with all of us. Let's listening the online webinar. Thank you. Over to you, sir.
Thank you. Now I request our Secretary, Dr. Kannan, to offer his Secretary report.
Good evening all. I am Dr. Kannan, Secretary, ISA Puthukkottai City Branch. Successfully, we are conducting 30th webinar of second edition of Puthukkottai Bhudhan today. Today, our topic is pediatric anesthesia. Our president has elaborated pediatric anesthesia. And last week, 6th August, we have conducted 29th webinar of second edition of Puthukkottai Bhudhan. Last week topic was traumatic brain injury. We have divided the topic into 3 subtopics. First one is pre-anesthetic assessment in neurotrauma. Second subtopic is management of acute traumatic brain injury. Third subtopic is management of subarachnoid hemorrhage. Our moderator was Dr. Prasanna Bidkar, Professor, Jipar, Puducherry. First subtopic, pre-anesthetic assessment in neurotrauma was done by Dr. Alsager, Senior Resident, Neuro Anesthesia, Jipmar, Puducherry. Second subtopic, management of acute traumatic brain injury was done by Dr. Sri Ganesh, Professor Nimans, Bangalore. Third subtopic, management of subarachnoid hemorrhage was done by Dr. Rahul Prasad, Consultant, Neuro One Hospital, Trichy. Last week, around 833 delegates have attended our webinar. Faculties in medical colleges, kindly encourage your postgraduates to attend our webinar continuously. It is very useful to the exam going postgraduates and consultants. Our academic chairman is collective knowledge, giving the collective knowledge to the webinar. We are very much thankful to our academic chairman, Dr. A.L. Meenakshi, sir. Thank you, sir. I hand over to you, sir.
Thank you, Mr. Secretary. Now it is my turn to introduce the speakers to the delegates. Today, we are fortunate to have faculty from the prestigious Lady Hardinge Medical College, New Delhi. And I want to inform all of you, Lady Hardinge Medical College is participating in the second time in the Puthukkottai Bhudhan webinar. Jipmar already participated, PG Chandigarh is willing. So this time, Puthukkottai Bhudhan has reached the masses through their minds and hearts. So minimum faculty attendance is 800. Because of the strength of the faculty, we could maintain the same tempo. And now many associations are calling us to organize the webinars. So I thank all the faculty for keeping the tempo at a high level. And today, as I said, the participants are from Lady Hardinge Medical College, and the youngest faculty is already a qualified anesthesiologist. Usually we will have a postgraduate as the faculty, the first faculty to start with. But this time she's a postgraduate, but she's a qualified anesthesiologist. So you may be wondering how it is possible. Dr. Harshini Muthyala, she has done her MBBS from Usmania Medical College, Hyderabad, and she has already covered her MD from Nizam's Institute of Medical Sciences. Both are prestigious institutes in Telangana. So she has finished her MD, but she is joined as a DM anesthesia, neonatal anesthesia and pediatric anesthesia in the prestigious Lady Hardinge Medical College. So she is a qualified anesthetist as well as the postgraduate, and she has won the second prize in the poster presentation in Telangana State ISA conference. And she is interested in reading, writing books and stories. And interestingly, she will write poems also. I don't know whether she will be writing Tears of Anesthesiologist as a poem or the Prestige of Anesthesiologist as a poem. I don't know. So she is the youngest graduate now, and we welcome you, ma'am, for this webinar. And it will be followed by Dr. Sashmita Das. She is an assistant professor from Lady Hardinge Medical College. This time it is peculiar. This is a grade. So far it had not happened in this 30 episodes. This is the first time we have a PG, we have an assistant professor, we have a professor and another director professor. So the grade is maintained, or else sometimes 2 associate professors will be there, 2 professors will be there, 2 assistants will be there. But this time it is methodical that 1 PG, 1 assistant, 1 professor, and another director professor. So this time the professor is going to be Dr.Preeti Harshini. So she is a professor in Lady Hardinge Medical College, and she is a professor of pediatric and neonatal anesthesia. Many of us may not be aware, because in most of the medical colleges, pediatric anesthesia will be only one theater. Our pediatric anesthesia will have a separate block. But this full-fledged department in Lady Hardinge Medical College is working for dedicated for pediatric and neonatal anesthesia, and her interests are airway and pain management. So because she is interested in airway, she is going to ventilate our brains with her knowledge, but that will be painless. I can tell you, it will not be full of pain. It will be painless. So we welcome you, ma'am. And
thank you, sir.
3 people, when a professor is participating, the moderation could be done by another professor. She is a director professor. She is Dr. Anshu Gupat, who has helped me even 3 months earlier she has booked the slot. She has fixed it as August 13th, 3 months earlier. And incidentally, I want to tell you, Lady Hardinge Medical College is having 2 professors in the name of Anshu Gupta. And I want to tell you, in our previous episode, another Anshu Gupta from Lady Hardinge Medical College participated. So I used to identify her as Anshu Gupta webinar, and she is Dr. Anshu Gupta Pediatric. So that is how I remember. So for the past 3 months, I'm talking to her. She was very kind and cordial, and she is not behaving. That is so-called authoritative behavior of a director professor is not with her. She is very kind, and she has so many achievements, because without that, how she can sit in the Lady Hardinge Medical College? So she has publications in national and international journals. She's an instructor for basic life support and advanced cardiac life support courses. So she is a faculty in first aid course, and she is a reviewer of journals. So even if somebody is giving painful lecture, madam will give the first aid for us to get relieved. So with this, I hand over the session to Dr. Anshu Gupta, Director Professor, Lady Hardinge Medical College, and our moderator for this webinar. Over to you, ma'am. Dr. Anshu, madam. And now I request Dr. Dr.Muthyala to go ahead with her presentation, Thermoregulation in Newborn.
Hello, everybody. Good evening. Firstly, I would like to thank you all for this opportunity to present a webinar on thermoregulation in children today. So we'll start off with the topic. So thermoregulation in children, I'll be covering the topic under the following headings: introduction, heat production and loss, physiological control, effects of anesthesia, measurement of temperature, and intraoperative hypothermia. Coming to the introduction. So what is temperature? Temperature. So temperature is a thermal state, and it defines whether an object or a body or a human gives heat or takes heat. So if two bodies are in contact and one is at a higher temperature, it loses heat to the object at a lower temperature. Then coming to human beings, we are homeothermic organisms. That is, human beings maintain a constant temperature independent of the surrounding temperature. Then anesthesia disturbs this thermoregulation through various mechanisms, which we will be discussing further in this webinar. And children or neonates are definitely at higher risk of this disturbance in thermoregulation due to various factors. Before going into the topic, we have to know two very important terms, that is neutral temperature and critical temperature. So coming to neutral temperature is the ambient temperature that results in minimal oxygen consumption. That is the temperature at which the oxygen consumption to maintain homeostatic mechanisms is the lowest. That is called a neutral temperature. And the second term is critical temperature, which is the ambient temperature below which an unclothed, unanesthetized individual cannot maintain normal core temperature. So these two temperatures are very important with respect to any patient, not only in pediatrics but also in adults. So if you compare the neutral and critical temperatures in various age groups, you can see here the preterm neonate has a neutral temperature of 34 degrees centigrade. A term neonate has a neutral temperature of around 32 degrees centigrade, and an adult has a neutral temperature of around 28 degrees centigrade. When you see the critical temperature, the preterm neonate has a critical temperature of 28 degrees centigrade, which means that if the ambient temperature or goes below the temperature of 28 degrees centigrade, the preterm neonate cannot maintain a constant core body temperature. That means the core body temperature further drops, leading to consequences of hypothermia. for term neonate, if you see, the critical temperature is 23 degrees centigrade, and for an adult, the critical temperature is 1 degree centigrade. So usually the OT temperature in a normal adult patient OT is around 18 to 22 degrees centigrade, which is way above the critical temperature of an adult. So the adult patients can still manage to maintain the core temperature in your normal OT temperature. But when it comes to pediatrics, the neonates and the preterm neonates, as you see on the slide, it is 23 and 28 degrees centigrade, which is mostly the OT temperature of around 23 degrees centigrade is almost always lower than that of the critical temperature in these age groups, which is why. Yes. Yes.
Hello, Rimpa, are you hearing me? Are the slides changing in the slide share?
Ma'am, I have stopped sharing since you have asked me.
You can restart sharing now.
Okay, okay, ma'am. Just a second.
Dr. Harshini, you please share your screen, and already as we have decided, you just click the screen because slide screen is not working for you.
Yes, yes, sir.
You just
Yes.
click one by one.
Yes, sir.
You click one by one.
So the critical temperature for a preterm neonate is 28 degrees centigrade, but your OT temperature is usually set around 22 to 23 degrees centigrade. So the critical temperature is higher than your OT temperature, which means that your neonate and preterm neonate are going to lose heat in your normal OT temperature, which is why it is important to maintain a temperature homeostasis. So coming to mechanisms in which heat is produced and lost, mechanisms of heat production are normally the basal metabolic rate of around 40 kilocalories per meter square per hour in your babies produces heat in a normal setting. And the other way is through voluntary muscle activity. The normal voluntary muscle activity also produces certain amount of heat, but under anesthesia the basal metabolic rate is reduced and also the voluntary muscle activity is reduced. So overall the heat production is reduced under anesthesia. So coming to the other mechanisms in which heat production occurs, one is shivering, but the other one is non-shivering thermogenesis. Shivering is not very well developed in children and in neonates. So the main mechanism of heat production will narrow down to your non-shivering thermogenesis. So how this non-shivering thermogenesis is happening in this age group? It is occurring through something called brown adipose tissue. So adipose tissue is nothing but your fat tissue. There are two types of adipose tissue. One is brown adipose tissue and one is white adipose tissue. So the brown adipose tissue gets its name from its color. These cells in brown adipose tissue are multinucleated cells which are very rich in mitochondria. So these high amount of mitochondria helps in heat production in the brown adipose tissue. So the brown adipose tissue is differentiated.
Harshini, you just click one by one slide because your slides show is not working. You
Yes, sir.
move the slides one by one, but you are
Sure.
moving the slides.
Sure, sir.
Be conscious about that.
Sure, sir. So the brown adipose tissue is differentiated between 26 to 28 weeks of gestation. So any preterm neonate will also have this non-shivering thermogenesis. Also, because of their thin skin, because of their low amount of subcutaneous tissue, and also because of their high body surface area to weight ratio, the neonates and children are prone to lose heat. So non-shivering thermogenesis becomes a very important mechanism in which heat is produced in this age group. So how this brown adipose tissue is generating heat is what is important here. So normally, if you take a normal mitochondria, during the metabolism, it helps in oxidative phosphorylation. And during the process of oxidative phosphorylation, ATP is produced. But whenever there is a drop in your core body temperature, the beta sympathetic stimulation happens in the brown adipose tissue through beta-3 receptors in the brown adipose tissue. And then there is activation of something called uncoupling protein 1. So this uncoupling protein 1 is present in the mitochondria, and that helps in this protons being diverted from ATP synthesis to heat production. So that is how thermoregulation happens through non-shivering thermogenesis. Next, coming to the mechanisms of heat loss. So we have seen how heat is produced. So it is important for us to know how heat is lost so that we can put a stop in these mechanisms intraoperatively. So there are four main mechanisms in which heat is lost. The first one being conduction, second one being convection, radiation, and then evaporation. So firstly, conduction. So what is conduction? Conduction is heat transfer through a solid medium. So for example, if you take a neonate who was placed on the OT table, there will be some amount of heat transfer between the body of the neonate and the OT table. So that heat loss is what you call conduction. So how do you prevent this conduction? You can use pre-warmed blankets which are placed on the OT table rather than directly placing your child on the cold OT table. So this conduction amounts to around 5 to 10% of heat loss intraoperatively. Next, coming to convection. Convection is the heat transfer through a fluid medium, which is like heat transfer through the air. So normally in when you place your child on the OT table and the surrounding air surrounding the child is cold, definitely cold. So what happens is some amount of heat is lost from the body of the child to the air which is immediately above the child, and that air will become hotter, and the density of air will increase and then will decrease. So that air will go to the top, and then the next layer of cold air will come onto the child. So this convection current continuously carries away heat from the body of the child. This amount of heat loss amounts to about 25% of heat loss intraoperatively. So this convection current you can prevent by using just a bear hugger, by creating a warm air environment surrounding your baby's body. Coming to the third mechanism, it is radiation. So radiation is nothing but heat transfer in the form of electromagnetic energy. So all the bodies emit heat in the form of electromagnetic waves. This is called radiation. So radiation depends on the temperature difference between two objects, the distance between two objects, and also the difference in the temperature between the two objects. And this amounts to the maximum or the major amount of heat loss intraoperatively, which is around 50 to 60% intraoperatively. Then the fourth mechanism is through evaporation, that is through in the form of vapor. There is a loss of certain amount of heat intraoperatively. This evaporation is more especially when large body cavities are opened, like in intrathoracic surgeries or in intra-abdominal surgeries. When all your intestines or bowels are outside, this evaporation is very high. So that has to be kept in mind, and maybe the bowel can be covered with a sterile warm NS fluid soaked gauze to prevent this evaporation. And one more mechanism of heat loss which is low but can be important is through your respiratory gas flows. Using high flows without a humidified gas will lead to loss of certain amount of heat intraoperatively. So always prefer low flows over high flows and humidified air. These, now we have discussed mechanisms of heat production and heat loss, so we come to the physiological control. So normally in a normal child there are receptors which sense your hot and cold temperatures. So the cold temperature receptors are A delta fibers nerve endings, which are called bulbs of Cross, and your warm receptors are type C nerve endings, which are called bulbs of Ruffini. So these two receptors help in sensing cold and heat temperatures in your body. Then these receptors are prone to adaptation. That is, when they are constantly subjected to a specific temperature between 20 to 40 degrees centigrade, they tend to get adapted to that temperature and stop giving signals to your center. So these two receptors are important, as in they sense your cold and heat temperatures. Next, coming to the center, the main center for thermoregulation is the hypothalamus. The impulses from cold and warm receptors go to your anterior hypothalamus initially, from where the information is relayed to the posterior hypothalamus. The posterior hypothalamus compares the temperature which is obtained from your A delta and C receptors with a set core temperature which is already preset in your body. In normally for us as humans, it is 36.5 to 37.4 degrees centigrade. So your hypothalamus compares the temperature which is sensed from your A delta and C fibers with this set temperature and decides whether the temperature is higher for you, or whether the temperature is lower for you, or whether the temperature is in a normal range. So this thermostat will recognize this temperature change and initiate a negative feedback loop. That is, if the temperature is lower, it will initiate mechanisms which will conserve heat. And if the sensed temperature is warmer, it will it will stimulate pathways which will lose heat. So what are the pathways which will conserve heat? One thing is, the first response to conserve heat is vasoconstriction, which happens at a temperature of a very low difference of around 36.2 to 36.5 degrees centigrade. So that is the first thing that happens when the temperature goes low. And next comes your shivering and non-shivering thermogenesis. So there is something called threshold temperature. That is, threshold temperature is different for different mechanisms, and it is defined as the temperature at which a specific thermoregulatory mechanism is initiated. As in, if you take vasoconstriction, the threshold temperature for vasoconstriction in an unanesthetized individual is 36.5 degrees centigrade. And similarly, for shivering, it is 36 degrees centigrade. For sweating, it is 37.5 degrees centigrade. And for vasodilation, it is 38 degrees centigrade. So these are certain terms which we have to keep in our mind. And the interthreshold range is around 36.5 to 37.5 degrees centigrade in an unanesthetized individual. But when you take thermoregulation under anesthesia, this interthreshold range is increased. That is, the threshold temperature for vasoconstriction drops to around 34.5 degrees centigrade, and the threshold temperature for shivering drops to around 34 degrees centigrade. Similarly, there is increase in the threshold temperature for sweating and vasodilation. So what does this mean? This means that if a normal patient is being exposed to lower temperatures, vasoconstriction happens at 36.5 degrees centigrade. But if the same patient is exposed to hypothermia under anesthesia, vasoconstriction doesn't come into role until the temperature drops to around 34.5 degrees centigrade. So that is how your anesthetics and anesthesia changes your physiological control by increasing the interthreshold range and decreasing the threshold temperature, or increasing for heat conservation, and increasing the threshold temperature for heat loss. Coming to the effects of anesthesia. So under anesthesia, as we have understood, there is more heat loss. So this happens in three phases. The first phase is called the phase of redistribution. This is the initial rapid phase where there is a rapid fall in temperature of from around 37 degrees centigrade to around 36 degrees centigrade. So this initial 1 to 1.5 degrees centigrade drop is very quick over the first 1 to 1.5 hours. And this happens because the core temperature of around 37 degrees centigrade is redistributed to the colder peripheries due to vasodilation under anesthesia. So when you anesthetized any patients, there is peripheral vasodilation that occurs. This peripheral vasodilation causes heat loss from the core to the peripheral tissues, causing a decrease in initial core temperature, which is your phase of redistribution. Then coming to phase 2, which is a linear phase. So in phase 2, there is heat loss, continuous heat loss, which is exceeding your capacity of heat production. That is, the patient tends to continuously lose heat in a linear fashion. Uh, Then you comes your phase 3, which is a thermal steady state. That is, in this phase, your thermoregulatory mechanisms come into play, and then the heat loss is counteracted by mechanisms which conserve heat, such as vasoconstriction and shivering, and your non-shivering thermogenesis in neonates. So these three phases are the phases in which your heat loss is happening under anesthesia. And when you combine general anesthesia with a neuraxial procedure, like when you combine, suppose GA with epidural, this effect is even more higher, and there is no thermal steady state obtained in the phase 3, and the patient continuously constantly loses heat even through the phase 3 due to vasodilation in combined general anesthesia with epidural. Coming to the next part, that is, so now we have learned different mechanisms of heat generation, heat loss, and effects of anesthesia on these processes. So how do we measure these processes intraoperatively? So the measurement of temperature, as we have seen, is important in all age groups, but even more important in when it comes to children. So this temperature measurement can be done through measurement of core temperature and also through the measurement of peripheral temperature. But there is a difference between the core and peripheries, as we have already discussed, and the difference can be up to 1 to 2 degrees centigrade difference. So the core temperature can be measured in various areas, the nasopharynx, the distal esophagus, the tympanic membrane, and the pulmonary artery, which is the gold standard for measurement of core temperature. But we regularly use nasopharyngeal probes for core temperature monitoring because it is easy to insert and also widely available in various setups. Then coming to the near core temperature or peripheral areas where you can monitor temperature, they are the axilla, the forehead, the bladder and rectum, and the oral cavity. The image which is shown here, the first one, is your nasopharyngeal temperature probe. You have to measure the depth of insertion properly, that is from the nostrils up to the tragus, and then insert that specific depth into the nostril of the child. And the second image shown here is a Foley's catheter with a temperature probe integrated into it. So this is a bladder monitoring of temperature. Then this image shows your esophageal temperature probe, which is placed in the esophagus for temperature monitoring. And this is a peripheral temperature probe, which is kept in the axilla or even on the thorax of the child. So out of all these things, pulmonary artery temperature is your gold standard. But we regularly can't use pulmonary artery catheters for all the simple cases. So we go for the nasopharyngeal probes if the patient is intubated, or even the axillary or peripheral temperature monitoring probes. The bladder and rectal probes are not very reliable because of the less blood supply to these organs, and also the variability in temperature monitoring that occurs with the contents of those organs. Then these temperature probes work on various principles depending on their how they are made. So three main principles are utilized in these temperature monitoring devices. One is thermistors. So these thermistors are devices which change their electrical resistance when there is a temperature change. So this change in electrical resistance is reflected with your temperature. Then the second principle is by using thermocouples. These thermocouples are semiconductors which use something called as the Seebeck effect. So basically, these are two different metals joined together, which when exposed to a certain temperature react differently. So because they are two different metals, they react differently. So this difference will give rise to generation of a voltage, which is detected by your sensor and reflected as the change in temperature. And the third one is by using infrared sensors, which are mostly the forehead and the temporal temperature probes. So the next one is, after discussing all these mechanisms of heat loss, heat generation, and temperature measurement, we have to know what happens when hypothermia is occurring and how to prevent and manage this hypothermia. So the consequences of hypothermia are, the first one being coagulopathy. So whenever there is a decrease in core temperature, which it causes a decrease in platelet thromboxane A3 release and decrease in platelet function. And it also causes decrease in your coagulation pathway, activation of your coagulation pathway factors. So by these two mechanisms, it can set in a coagulopathy and cause increased bleeding intraoperatively, which is very important in children. The second one is surgical site infection. So, as we have discussed, vasoconstriction as one of the mechanisms through which heat is conserved, it has a negative effect. That is, whenever your blood supply is decreased to the peripheral tissues through vasoconstriction, the wound healing is impaired. And also, the hypothermia sets in certain immunomodulation and decreases your immune response. So, by these two mechanisms, the increased incidence in surgical site infections is seen with hypothermia. Then the next one is prolonged drug effects, which we are all afraid of as anesthetists. This can happen in hypothermia due to decreased drug metabolism intraoperatively, and then also due to decreased hepatic blood flow because of hypothermia, which can impair the drug metabolism. And the MAC, or minimum alveolar concentration of your inhalational agents, decreases with hypothermia. That is, for every 1 degree centigrade drop in your core temperature, there is decrease in MAC by 5%. So that we have to keep in mind regarding the prolonged drug effects in hypothermia. And then the next one, which we have to keep in mind, is shivering. So how does shivering create problems? Shivering is nothing but involuntary skeletal muscle activity. So this skeletal muscle activity will take up a lot of oxygen, and it will increase the oxygen demand by 2 times. So this will impair your intraoperative normoxia, and also the muscle splinting effect is lost when there is shivering, which will lead to increased pain and inadequate analgesia in your child. Then the next one, which is the deadliest and most afraid or scary situation, is a myocardial ischemia. So hypothermia initially initiates your sympathetic response, and this sympathetic response can activate pathways which lead to malignant arrhythmias intraoperatively, which can increase your myocardial oxygen demand, and combined with your decreased oxygen supply can cause a myocardial ischemia. So all these are the consequences of hypothermia, which we don't want. So how do we prevent and how do we manage this hypothermia? So the prevention of hypothermia starts before the shifting the child in. So you have to shift the child in a pre-warmed blanket, the child nicely wrapped in a blanket, or if available, you can use an incubator to shift the child. We regularly use incubators to shift the preterm neonates and also neonates. With these incubators have a set temperature, and these they have a battery backup also, so they can be used during the shifting process, while shifting the patient in and also while shifting the patient out, to maintain normothermia during the shifting process, so that the patient comes in warm. Then the second thing is pre-warming before induction of anesthesia. So you make sure the OT temperature is set at a higher temperature, and then you use warm linen on the OT table to place your child. Then the next one is passive insulation. So passive insulation is through using blankets on the child to cover the child properly. Intraoperatively, and also after the child is shifted onto your OT table. Then porous versus non-porous surgical drapes. So even the type of surgical drape that is used affects your temperature control. So porous surgical drapes like linen and cotton are porous materials, so they allow heat to be lost to the environment, and they also allow water and other things to seep in onto the child, causing even more temperature loss. So using non-porous surgical drapes is better to prevent hypothermia. Then using of active warming devices like your bear hugger to prevent the convectional currents from taking away heat from your child. Then using of fluid warming devices like your this fluid warming comes into role when you have to give a large volume of fluid, or when you have to give a blood transfusion, especially to your child. So 1 liter of fluid can decrease the temperature of your child by around 0.25 to 0.5 degrees centigrade, and one cold blood transfusion can decrease your temperature of the child from 0.25 to 0.5 degrees centigrade. So before giving a huge fluid bolus or before giving a blood transfusion or blood products, make sure that they are warm. Then use of low gas flows with carbon dioxide absorbent. As I have already discussed, low gas flows will cause preservation of heat and moisture within the circuit. So it is very much better to use low gas flows with this carbon dioxide absorbent rather than using your semi-closed circuits with high gas flows. Then you have to maintain normoxia and normoglycemia along with hypothermia, because if the child is hypoxic, that will cause sympathetic stimulation. Even if the child is glycemic, that will cause sympathetic stimulation. And any kind of sympathetic stimulation is bad for temperature management, because any sympathetic stimulation will cause the increase in metabolic activity, and your heat and energy is all diverted to that pathway rather than to the pathways which conserve heat. So hypoxia and hypoglycemia can cause hypothermia. So it is important to maintain your normoxia and normoglycemia. So as we have discussed, the hypothermia management starts even before the patient shifts in, and it doesn't end when you shift the patient out. So you have to maintain the temperature throughout the transit period, when you are shifting in, when the patient is on the table, when the patient is off the table, when the patient is being taken outside the OT.
Ashni, will you please wind up fast?
Yes, ma'am. So these are certain devices. The first one is a radiant warmer, which can be used in the OT and also in the pre and post-op areas. This one is a fluid warmer. This is a hotline, which is again a fluid warmer. This is a bear hugger. And this is a summary of how to manage the hypothermia: ambient temperature control, forced air warmer, fluid warmer, patient on a warm mattress with low gas flows. This ends my presentation. Thank you very much for the opportunity.
Thank you, Harshini. And we'll be taking questions at the end of the session. And I think it was quite well explained. We have to understand that temperature management is very important, especially in small babies.
Yes.
And we have to, so I'll move on to the next talk. Uh, the next talk is by Dr. Preeti Goyal Vashne. Dr. Preeti Goyal Vashne is professor in the Department of Pediatric and Neonatal Anesthesia, Lady Hardinge Medical College. And her areas of interest are airway and pain. She'll be talking about a child with inguinal hernia, and along with ASD as a comorbidity. And all of us know that when you are in exam, you get short cases. Pediatric cases are usually given as short cases, and most of you get pediatric cases. So you have to here we are going in a little detail, but in exam you have to give positive history, important negative history, important examination, and diagnosis. But you have to know and all about pediatrics. Okay, so Dr. Preeti, please.
Thank you, ma'am, for the introduction, and thank you, Sundaram sir and organizers for giving this opportunity. So I'll be talking about anesthetic management of pediatric inguinal hernia and ASD. So you get it as a short case, as Dr. Anshu has already explained. So my talk will go through a little introduction, pre-operative assessment, ASD, little bit about ASD, anesthetic considerations, anesthesia technique, and post-operative care. So inguinal hernia is one of the most commonly performed pediatric surgery, and it is common in premature, in neonates, and on right side. It is basically an indirect hernia with patent processus vaginalis in almost 80 to 100% of the neonates at birth. But usually it closes by 6 months. But in neonates where it persists, it comes as, the patient presents as hernia. There are mainly abdominal contents in the process, but the repair is done to prevent bowel incarceration or damage to the gonets. It is an elective procedure, and it is done as an emergency in children who show the signs of bowel obstruction. So as we start taking the history, most commonly the child presents during the first year of life with a swelling in inguinal-scrotal region since few months as noticed by the mother, usually painless swelling and gets relieved on lying down. If it is associated with vomiting or abdominal distension, constipation or fever, then it indicates obstructed or strangulated hernia. So we also ask for history related to associated congenital anomalies, any other deformities, congenital heart disease, or related to airway. So with inguinal hernia, the other congenital anomalies which can be associated are genitourinary disorders like undescended testes or hypospadias, cystic fibrosis, prematurity related anomalies, connective tissue disorders, and abdominal wall defects. So history specific to congenital heart disease, history of cyanosis or cyanotic spells, feeding history like patient having poor weight gain or poor feeding indicating failure to thrive. If there is history of frequent pneumonia, like that can be due to increased pulmonary blood flow. If the patient is having currently any upper respiratory tract infection, then drug history and history suggestive of cardiac failure like breathlessness, recession, or nasal flaring. Also, as usual, we'll ask for birth history, full term or preterm, admission in NICU, or the baby cried immediately after birth, then past history, dietary, vaccination, development history, motor and social development, and pertinent maternal history. That is important. For examination, general physical examination is same as we do for any other patient, but we have to comment upon the patient child being conscious, active, lying comfortably, or irritable. Then we measure the height or the length of the patient up to 2 years of age and weight, and we always tell that it is appropriate for age or not. Also, besides other things, we check for fontanelles, anterior and posterior. Vital signs have to be measured. Airway examination is very important because that can indicate some congenital anomaly, or with congenital anomalies, the airway can be difficult. It can be a difficult airway. Developmental examination is very important. Gross motor, fine motor, for that age, we have to examine for that, and also feel for the spine, posterior superior iliac spine and sacral hiatus for the feasibility of caudal block. Systemic examination, cardiovascular system, since it is case of atrial septal defect, it is typical to have systolic ejection murmur in the second left intercostal space. There can be chest deformity. We look for heart enlargement. Normal position of the cardiac apex is 4th intercostal space inside the nipple line in a child less than 5 years. Then respiratory system, per abdomen, CNS, and local examination is important. So what can be the associated syndromes when a patient is having hernia and with congenital heart disease? The patient can have Down syndrome or trisomy 21, charge, which is coloboma, heart defect, choanal atresia, growth retardation, genital and ear anomalies, Vater, DiGeorge syndrome, and may have airway abnormalities also. So what investigations will we do? Routine investigations, hemoglobin and urine iron, we do it for every patient. Hemoglobin can show anemia, which indicates poor feeding, or polycythemia, which shows chronic hypoxemia. We have to go for echocardiography to see the type of lesion. Here it is ASD, the size of defect, shunt, whether it is left to right or right to left, pulmonary artery pressure, very important. Normal is less than 25 millimeters of mercury. ECG will go for only those patients who have large ASD or long-standing defect, and it might have the patient might have right exit deviation and right bundle branch block in such condition. Chest X-ray might show prominent pulmonary markings or vasculature. So, little bit about atrial septal defect. It is mainly ostium primum, secundum, or venosus defects. These are the 3 kinds of atrial septal defects. Secundum is the most common, and it is basically a patent foramen ovale. We call it, when the patency is more than 5 millimeter, we call it as a ASD. It is basically a left to right shunt. If the defect is less than 0.5 centimeter, we say it is a small shunt and there is mainly no hemodynamic sequelae. But shunt is considered large if the defect is more than 2 centimeters, leading to excessive pulmonary blood flow, and the patient will be symptomatic. So if this is a left to right shunt, normally this left side, which is systemic vascular resistance, is higher than the pulmonary vascular resistance. That's why it is left to right shunt. So if this SVR falls or the PVR increases, then there can be shunt reversal from right to left. And also there can be increase in shunt fraction if there is fall in PVR, pulmonary vascular resistance, or increase in systemic vascular resistance that will cause exaggeration of left to right shunt. This is very important to understand. And if there is long-standing or large shunt, then because of the left to right shunt, the right ventricular volume overload is there and the pulmonary blood flow increases, which causes right ventricular hypertrophy over time and increase in PA pressure. So what are the factors affecting pulmonary vascular resistance? Increase in pulmonary vascular resistance can happen because of hypoxia, hypercarbia, acidosis, sepsis, atelectasis, and high airway pressure. Increase in pulmonary vascular resistance will lead to reversal of shunt. Decrease in pulmonary vascular resistance will cause increase in shunt fraction left to right. So high FiO2, that means 100% oxygen, or anemia are two main things which can lead to increase in shunt fraction during the intraoperative period. This National Surgical Quality Initiative Program have given a risk stratification strategy for the patients with congenital heart disease. Our patient having ASD and minor surgery, that is inguinal hernia procedure, will come under low risk, so we have to proceed with caution. If the patient comes under moderate or high risk, then we have to have a multidisciplinary team and we might need to refer to specialist center. So what are the anesthetic considerations in such case? Number one, considerations related to pediatric age group, concerns regarding atrial septal defect, associated congenital anomalies and syndromes, if any. Then inguinal hernia is a daycare procedure, so we have to have provision for appropriate drugs and equipments and provision of post-operative pain relief, very important. Coming to pediatric considerations, pediatric age group is different from adults in terms of anatomy, physiology, and pharmacology, and they're more prone to bradycardia, desaturation, hypothermia, and post-operative apnea. So anatomical features which are different, they are obligate nasal breathers up to 6 months of age. This potential difficult airway because they have large head, prominent occiput, large tongue, anterior and cleft larynx, long and omega-shaped epiglottis, slanted vocal cords. Also, they have horizontally placed pliable ribs and there is risk of laryngospasm. Prominent tonsils and adenoids can be there, loose tooth can be there, and there can be difficult IV access. How are they different physiologically? Respiratory system, they are prone to rapid desaturation and more prone to hypoxemia, atelectasis because FRC is less and airway resistance is high with high chest wall compliance, as well as increase in oxygen consumption. The respiratory muscles are weak, easy fatigability is there, and they might have viral URTI. With CVS, we have to be careful with volume status and fluids, which is basically heart rate dependent cardiac output. High vagal tone is there and there is blunted response to catecholamines. Renal blood flow is reduced, especially with limited GFR up to 2 years of age. So we have to be careful while using NSAIDs. Also decreased hepatic blood flow in newborns. P450 enzyme system is not fully developed and the children are prone to hypoglycemia because of poor glycogen reserve. There is blood-brain barrier is immature and they are more sensitive to the anesthetic drugs. Pharmacologically, the total body water is more, so there is increased volume of distribution for hydrophilic drugs. Protein binding is lesser, immature hepatic and renal function as already told. The neuromuscular junction is also immature and they are more susceptible to malignant hyperthermia. One important aspect is psychological. So up to 6 months, there is stress on the family because they are stressed for abandoning the child. From 6 months to 4 years, there is separation anxiety in the child. So coming to the second point, concerns related to ASD. So we have main concerns are We have to be careful for increase in shunt fraction. As I've already told you, left to right shunt might increase intraoperatively. Shunt reversal, that is right to left shunt, can happen. Congestive heart failure and paradoxical arterial embolism. So what are our hemodynamic goals as per ASD? We have to avoid an increase in systemic vascular resistance because it will cause increase in shunt fraction. How? We have to avoid light plane of anesthesia, hypertension and hyperventilation. We have to also avoid decrease in pulmonary vascular resistance by avoiding high FiO2 and hypocarbia. We have to avoid fluid overload and risk of congestive heart failure. And for air embolism, we have to meticulously de-air the IV lines. We have to avoid introducing air bubbles because anytime if there is transient shunt reversal as during cardiac cycle, there is a phase when right atrial pressure is equal to left atrial pressure. So this can lead to escape of air from the right side to the left side to the systemic circulation. So what preoperative orders we will give? Fasting, as we all are aware, ASA guidelines, 6 hours for solid food or formula feed, 4 hours for breast milk and 2 hours for clear fluids. ERAS says minimal perioperative fasting, preoperatively as well as postoperatively, but we'll stick to 2 hours for clear fluids. Although European guidelines say 1 hour. We have to take informed consent by parents and legal guardians. Pre-medication is important because separation anxiety is there in a child of more than 6 months. And infective endocarditis prophylaxis. Okay, do we really want to give IE prophylaxis? How do we decide? So there are very specific guidelines for IE prophylaxis. There are cardiac indications and surgical indications. So cardiac indications are very, very specified with prosthetic cardiac valves or previous infective endocarditis or CHD with unrepaired cyanotic, PHD with palliative shunts, completely repaired congenital heart disease with prosthetic material. So there are very specific indications. For surgical procedures also, dental procedures involving only when they involve gingival tissue or perforation of oral mucosa. Not all dental procedures require IE prophylaxis. And there are other indications. Gastrointestinal or genitourinary procedures also only in IE prophylaxis is required when they have established GI or GU infection. So how do we prepare the OT? The OT should be pre-checked, pre-warmed, age-appropriate equipment should be there. We have to prepare for regional anesthesia, IV set, burette set for pediatric age group, and calculated dosage chart should be ready according to the weight of the child before induction of anesthesia. What are the options for pre-medication? We are using oral midazolam mixed with orange juice or with the dextrose, which is available in the OT, 0.5 milligram per kg, 30 minutes prior to surgery. Intranasal dexmed can be used and IM ketamine can also be used. So how do we plan our anesthesia? It depends whether the hernia surgery, hernia repair is open or laparoscopic. So for open surgery, the option is general anesthesia with supraglottic airway with assisted ventilation or general anesthesia with endotracheal tube with controlled ventilation along with ultrasound guided regional block or caudal block for pain relief. Spinal anesthesia is an alternative in only high risk patients who are prone to postoperative apnea or if the child is very small age. For laparoscopic surgery, of course, we want controlled ventilation, GA with supraglottic or endotracheal tube with muscle relaxant and can be supplemented with ultrasound guided regional block. So for induction of anesthesia, WHO checklist is mandatory to confirm the site of surgery. Then we can go for inhalational induction or intravenous induction. Inhalational induction with sevoflurane is the agent of choice when the IV access is delayed or is not there. Because the sevoflurane has low blood gas solubility, rapid inhalation induction, it is less pungent, but we have to be careful about hypotension. For IV induction, IV access is definitely has to be there and EMLA cream can be applied if available. Then we have to choose the agent with maintained hemodynamic stability. We have to give the agent slowly and titrated doses. And propofol boluses have to be avoided because it lowers the systemic vascular resistance significantly. So this table shows the hemodynamic effects of induction agents. As we can see, propofol causes marked decrease in SVR, and if there is a fall in SVR, then there are chances of shunt reversal. Ketamine is considered very good because it maintains all the things. Midazolam, we are not using for induction of anesthesia as such. Etomidate is good. Fentanyl decreases heart rate, SVR, and cardiac output, but if we give titrated doses, it is very good to use. And as I've said, sevoflurane, we have to be careful about hypotension. So for airway management, as I have told, we can use supraglottic airway device and endotracheal tube. With endotracheal tube, it is must to have muscle relaxant and controlled ventilation. With supraglottic airway device, spontaneous ventilation is not advisable, especially in very small children with heart defect. Assisted and controlled ventilation is acceptable. But at all times, we have to avoid hypoxia, hypercarbia, acidosis, hypothermia, hypotension, and tachycardia. So we have to maintain normocapnia, EtCO2 of 35 to 45 millimeters of mercury. As I've already explained, unassisted spontaneous aspiration may compromise ventilation and shunt stability. Controlled modes or assisted spontaneous breathing are preferred to maintain efficient gas exchange, stabilize the pulmonary and systemic respiratory resistance, and to ensure the consistent hemodynamics. Just to show you, most commonly we are using this iGel, supraglottic airway, and the ProSeal, and we have to know the proper size which has to be selected and the air required to inflate the cuff in ProSeal. Obviously, iGel has a gelled cuff. Endotracheal tube size also cuffed and uncuffed, for what age and for what weight we should be able to know. We should be aware about them. So coming to monitoring, standard monitoring is required, oxygen saturation, end-tidal CO2, ECG, and blood pressure. And invasive arterial monitoring is required only in patients with significant hemodynamic concerns. So how do we manage pain? Pain management starts pre-operatively. We always plan it. So intraoperatively, we can give systemic acetaminophen, paracetamol we are giving intravenously 15 milligram per kg. Regional, with caudal, ilioinguinal, iliohypogastric nerve block, or local infiltration of the surgical site. So caudal, most commonly we are performing landmark-based technique by palpating posterior superior iliac spine and then sacral hiatus, making an equilateral triangle. This shows that we pierce the sacrococcygeal membrane. Two things which are important is dura ends at S3-4 at birth and at S2 at 1 year. So dural, we have to be careful about dural puncture because dura ends lower down. Also, sacrococcygeal membrane is cartilaginous at birth but ossifies with increasing age. So the block becomes technically difficult after the age of 8 years. If we are using ultrasound, you can see transverse view. These are the sacral cornu, and we call it as frog's eye sign. And when we do longitudinal view for in plane needle technique, we see the bird beak sign. This is the sacrococcygeal membrane, and this is the posterior surface of sacrum. So a little bit about, because it is asked in exam, test for caudal block, we have to confirm the correct placement of needle by giving a whoosh test or swoosh test. Whoosh test is small amount of air is injected and we listen for a whoosh sound over the spine. And for swoosh test, same thing, but we use LA or saline injection instead of air because obviously we are worried about air. If it goes intravascular, then there are chances of air embolism. So swoosh test is better. Dose for caudal block, we have to use appropriate volume based on the surgical level. Armitage formula was used previously. Now we are using modified Armitage formula. So for sacral segments, 0.5 ml per kg. For thoracic, up to T10, 0.75 ml per kg. For lower thoracic, 1 ml per kg, and mid thoracic is 1.25 ml per kg. Adjuvants are recommended. Clonidine, fentanyl, or dexamethasone, or morphine, or epinephrine can be used. But we have to always consider the maximum safe dose and the patient factor. A little bit about ilioinguinal nerve. It is the L1 branch of lumbar plexus, while iliohypogastric is T12 L1 branch. They both are basically present between the transversus abdominis and internal oblique. This is the internal oblique, external oblique, internal oblique, transversus abdominis. This is the anterior superior iliac spine. And between these two, this is the fascia where ilioinguinal and iliohypogastric nerve is there. So we give ultrasound guided nerve blocks. So post-operative considerations, monitoring is very important for signs of hemodynamic instability or arrhythmia or respiratory complications. Adequate pain management to prevent the sympathetic stimulation, which can increase the cardiac workload. And we have to carefully manage the fluids to avoid volume overload, which can exacerbate the right heart strain. Discharge criteria according to the modified Eldred score, and we resume the feeding on demand. All former preterm infants of less than 60 weeks should be admitted after inguinal hernia repair for apnea monitoring. So this is modified Eldred score considers respiration, oxygen saturation, consciousness, circulation, and activity. To summarize, pediatric inguinal herniotony is a common procedure from an anesthetic perspective, and we need to understand the pediatric physiology, careful preoperative assessment for congenital anomalies and optimization. We have to customize our anesthetic technique, intraoperative monitoring, and we have to do a proactive postoperative care. Obviously, multidisciplinary communication and individualized planning is required to ensure safe care. These are the books which can be read. Thank you.
Thank you, Dr. Preeti. Very well explained. So, although Dr. Preeti has shown many books, but what I would suggest is for postgraduates, Miller has given a very nice chapter on pediatric anesthesia, and all of you should go through that. Another thing is, whenever you you will, like most of us in our hospital, it is a trend to give one pediatric and one adult case. Otherwise also you might get it very frequently in exam, or small babies are usually given in a in theory exam as a case management in third and fourth paper. So you have to first of all, you have to just think in mind, so what is the basically what is the weight of, as if you're doing the case, what is the weight of the baby, what are the doses I have to give, whether how much fasting I will keep, whether I have to give any pre-medication. If yes, you should know exactly how you would go about it, and what if IV line is there or not. If IV line is there, then you have two choices, IV or inhalational. If there is no IV line, the only choice is inhalational followed by IV line, and then you can go about whatever you want. So these things, if they are in your mind, it will be better. What size LMA I will use. If intubation, there is a formula, age upon 3 plus 3.5 for less than 6 years of age, age upon 4 plus 4.5 for more than 6 years of age. So that all you should know. How do I, whether I, then there are some questions like whether you will use cuff tube or uncuffed tube. So these, now you have to be prepared for these questions to answer them. What fluid I will use. Usually nowadays 1% or 2% dextrose is advised, and ringer lactate for losses, or balanced solutions for losses. So then how much I will give. So that you have to know, like 246 for formula is usually used according to the this surgery, the amount of loss you expect. So all those things you have to know. And then obviously whether I'm going to do some regional block along with that, and speak whatever you know. So these things are very important. So now we are moving from CVS to CNS. Our next speaker is Dr. Sashmita Das. She will be speaking on hydrocephalus and meningomyelocele. Dr. Sashmita, please.
Good evening.
I hope my screen is visible.
Yes, it's visible.
Yeah, so you just need to command me next, ma'am, then I will change the slide.
Okay, thank you.
Yes, ma'am.
Good evening, all. Today I'll be speaking on hydrocephalus and meningomyelocele, their concern and anesthetic management.
Dr. Sashmita Das is the assistant professor in Lady Hardinge Medical College in the Department of Pediatric and Neonatal Anesthesia.
Next slide. So I'll be speaking on hydrocephalus and meningomyelocele, their concern and anesthetic management. Next. First, let's talk about the hydrocephalus. Hydrocephalus, next. Hydrocephalus, what is hydrocephalus? It is the excessive collection of the CSF fluid. It can be because of three reasons. Either there is increased production, second, there is obstruction to the flow, and thirdly, there is reduced absorption of the CSF. All these things will lead to rise in the ICP. Next. So the normal range of intracranial pressures in term infants is around 1.5 to 6 millimeter of mercury, and in children it is 3 to 7 millimeter of mercury, and in adult it is 7 to 15 millimeter of mercury. The total volume of CSF in adult is around 150 ml approximately. Out of the total volume of the CSF, only 20% is present in the ventricle. Rest 80% of it is present in the subarachnoid spaces, in the cranium and the spinal cord. And the rate of CSF production is 20 ml per hour. Next. So here in this diagram, we can see the lateral ventricle, the fourth ventricle. Okay, so the CSF is produced from the coracoid plexus, and then it comes down to the lateral ventricles. From the lateral ventricles, it reaches the third ventricle through foramen of Monro. From the third ventricle, it comes to the fourth ventricle through aqueduct of Sylvius. And from the fourth ventricle, it goes into the subarachnoid spaces and cranium and spinal cord through one foramen of Mechenti and two foramen of Lushkas. This CSF fluid then goes and get reabsorbed into the venous sinuses. Next. So coming on to the types of hydrocephalus, they can be communicating and non-communicating, or a normal pressure hydrocephalus, or hydrocephalus ex vacuo. So in a non-communicating hydrocephalus, since the name is non-communicating, that means there is an obstruction to the flow of the CSF. So, and this is the most common type of hydrocephalus. And communicating is the non-obstructive type of hydrocephalus. Normal pressure hydrocephalus, there is usually a normal ICF or an intermittent increase in the intracranial pressure. And in hydrocephalus ex vacuo, there is no increase in the intracranial pressure, since there is a compensatory enlargement of the CSF spaces in response to the brain parenchymal loss. Okay, the examples can be post-trauma or in patients with schizophrenia. Next. So the etiologies are for communicating can be congenital or acquired. Congenital causes are like achondroplasia, craniofacial syndromes, other skin-based, skull-based deformities. Or acquired the causes can be subarachnoid, intraventricular hemorrhage, or some coracoid plexus papilloma or carcinoma, or it can be because of some infection. In the non-communicating type, it can be, the reason can be congenital or acquired. The congenital can be like aqueductal stenosis, and then Sherry malformation, X-linked hydrocephalus are also there, and then Wendy-Walker malformations. Other than congenital, the acquired reasons can be because of some tumor, or post-inflammatory, there is some adhesions, or because of some cerebral hematomas or infarct. Next. The diagnosis. The patient usually presents the infant present with vague signs and symptoms. We can present with mild symptoms like headache, nausea, vomiting, irritability, and poor feeding or lethargy. And the signs that we have to see is that the mother will, there will be an increase in the sequential head circumferences, and also bulging frontanels can be seen. Sunset sign can be observed, that is the sundowning of the eyeball. The eyeball will be drooping down because of the increased ICP. Because of the raised ICP, there could be associated motor deficits in the patient. Also, we will be able to elicit some signs of the increased ICP, like cushion response, which is bradycardia, hypertension, and your irregular respiratory pattern. Also, because of increased ICP, we can observe papilloedema and also some pupillary changes when we do a fundus examination. Next. In the investigation, we have to take a serial head circumference measurement, and we can get an X-ray skull done. In the X-ray skull done, we'll be able to see some in appearance like beaten copper cranial appearance. Also, we can get a transcranial Doppler done, in which we will see the raised flow of the blood vessels. And in the fundus examination, we'll be able to see the signs of papilloedema. And CT scan and MRI, in that we'll see dilated ventricle. Also, it is known as the Mickey Mouse sign because of the dilated ventricles. Next. The treatment includes your medical treatment and surgical treatment. In the medical treatment, furosemide are given, diuretics are given, but this medical treatment is usually very temporary. Again, after giving the medical treatment, usually the symptoms reappear, that hydrocephalus again develops. So the definitive treatment for this is the surgery, in which we do a shunt surgeries. So the different type of surgical methods that are available are like endoscopically, we can do a third ventriculostomy, also shunt surgeries. There are 3 types of shunt surgeries: ventriculoperitoneal shunt, ventriculoatrial shunt, and ventriculopleural shunt. The name is because in the right side you can see in the diagram, this is a catheter. This is a shunt catheter in which the peripheral, the distal end is named where it is the CSF is to be drained. Okay, and the proximal end stays in the ventricle. Therefore, the names are ventriculoperitoneal. This means the proximal end will be in the ventricle and the distal end will be in the peritoneum. Okay, so like that, we have ventriculoatrial and ventriculopleural. Those shunt can also be classified as low pressure shunt, medium pressure shunt, and high pressure shunt. Next. Here in this picture, we can see a shunt is been placed. So the proximal end is in the ventricle and the distal end is in the peritoneum. So the indication can be an elective or emergency. In elective, where elective indications are like where the patients have chronically raised ICP, whereas in the emergency situations are like patient present with respiratory arrest, coning, coma, where we can see the acute rise in ICP. Next. Coming on to the anesthetic concerns. So the anesthetic concern, we can divide it into like 3 parts, like the anesthetic concern because of the age group, since most of the patients are pediatric and neonatal age group patients. All the concerns related to that age group, which beautifully explained by Dr. Preeti in the previous talk, need to be carefully considered. Second, because of the hydrocephalus itself, and anesthetic concern related to the surgery and BP shunt. Next. So coming on to the preoperative assessment. So we have to take a detailed history of the patient, any current medication patient can have. Patient with hydrocephalus may develop, because of the raised ICP, may develop seizures. So patient might be on anticonvulsants, and also the patient might be taking some medical treatments for the hydrocephalus like diuretics, estrazolamide. Also, we have to see if the patient has any, in the history, we have to rule out any comorbidities. So these hydrocephalus are associated with many congenital disorders. And in the chronic raised ICP patients, we might get a patient who already had undergone a VP shunt surgery before. In those patients, they are at a risk of recurrent respiratory infection because of the shunt. And tunnel, because it is tunnel inside the skin, so there are high chances of getting infection in that areas. Also, we have to see ask for the neurological dysfunction in the patient. A thorough examination needs to be done, especially the airway, the respiratory system, CVS, and the neurological. Airway, because most of these patients are associated with other congenital disorders, so they might have the congenital facies. Because of that, they might have a difficult airway. Also, the volume status, the pulse need to be assessed properly, because these patients, because of the raised ICP, they have repeated episodes of vomiting, which ultimately leads to dehydration. We have to ask for the last oral intake. Next. What investigation that we can get from this patient? A hemogram is very important, and with clotting parameters. Urea and electrolytes, since these patients have multiple episodes of vomiting. An ABG and chest X-ray, and other investigation if there are associated comorbidities. So when we take the patient for surgeries, pre-medication. So we should avoid sedation in these patients, because sedation, what it will do is that the patient already is having a raised ICP. And when we give this sedatives, this patient can undergo respiratory depression. Because of respiratory depression and hypoventilation, they will have raised CO2 in the blood. Because of the increased hypercarbia, they again will have, which will lead to again increase in the ICP. So we want to avoid this raised in the ICP. Therefore, we should avoid sedatives in these patients. Also, if the patient is very anxious, sedatives like short-acting sedatives like midazolam can be given, but only under observation. Next. Intraoperatively, all the standard monitoring should to be done, and if any comorbidities are there, if there is congenital some cardiac abnormalities, then intraarterial BP monitoring can be done, invasive monitoring. Coming on to induction of anesthesia, the main aim for us is that we should avoid any acute rise in intracranial pressure, and also at the same time we need to be very careful to avoid any fall in the cerebral perfusion pressure, that is any form of hypotension. Next. If IV access is present, and along with the features of raised intracranial pressure, intravenous induction is always preferable over the inhalation induction. Also, when we talk about the intravenous agents, anesthetic agents, thiopentone, propofol can be used safely, whereas we should keep it in mind to avoid ketamine, since it raises the ICP. Also, in the inhalation, the more irritant inhalation agents should be avoided, like isoflurane and desflurane. For analgesics, previous slide please. For analgesia, short-acting opioid needs to be used, and muscle relaxant for in case of emergency surgeries. Scoline can be used, but we have to weigh that if the risk of aspiration overweighs the risk of transient increase in the ICP, then only scoline can be used. Otherwise, scoline has to be avoided. So what can we use as a muscle relaxant? We have to use non-depolarizing muscle relaxants. While securing the airway, a very gentle laryngoscopy need to be done, so that there is least increase in the ICP. And what can we use? A ET tube or a LMA? Preferably, ET tube is used, and also flexometallic is preferred, since they turn the head the position of the head is on the one side, they flex the head towards the one side. So that's why flexometallic tube is preferred. LMA can be used, but then again, the problems related to the positioning, because the head is turned towards the right side. To displacement of LMA, there are high chances of that. So we need to keep that in mind. Therefore, we prefer an endotracheal tube only. Next. So coming on to the airway part, since the head is very large, so how to position the head for adequate laryngoscopy? A roll below the shoulders can be put, and also the head can be brought to the edge of the table and it is supported by the assistant. Thirdly, the intubation can be done in a lateral position. Next. Positioning for the surgery, the position is usually a supine position and the neck is turned to the opposite side. So we need to be, but when the neck is turned to the opposite side, we need to be very careful that it should be done very gently, because excessive neck flexion may lead to impedance in the venous flow, leading to increased ICP in that area to the head. And as shown before in the picture, a roll below the shoulders can be put. This position also facilitate the tunneling of the shunt. And after positioning of the patient, ET tube has to be checked. The placement of the ET tube has to be checked, because after positioning, the ET tube might come out because of the position. So we need to be very careful regarding the placement of the ET tube. Second, next. The goal should be to avoid fall in the BP and cerebral perfusion pressure, and to avoid any rise in the ICP. So maintenance can be done with using an inhalation agent with MAC not more than 1. And nitrous oxide should be avoided in this, because nitrous oxide increases the cerebral blood flow and thus the cerebral blood volume, which will ultimately lead to the increase in the intracranial pressure. Short-acting opioids can be used and non-nebulizing muscle relaxants. Next. So what are the, we'll see the intraoperative management during like tunneling of the shunt surgery. Tunneling of the shunt catheter. So when they do the tunneling of the shunt catheter, there is usually an increase in the sympathetic response. So what we need to do is that we need to increase the depth of the anesthesia, either by increasing the inhalation agent or by giving additional doses of the short-acting opioids. Since these children have a high risk for hypothermia because of the large area is exposed, so warm fluid need to be used, and we need to cover the patient as much as possible. And also along with that, warming devices can be used. In these surgeries, the goal is to maintain the cerebral perfusion pressure. So the fluid, normal saline are commonly used to replace the fluid, and dextrose containing fluid should be avoided, since these lead to the edema of the brain tissues. So we further leading to the increase in the intracranial pressure. So this dextrose containing fluid should be avoided. Again, the extubation should be very gentle, rapid. We should try, the goal should be to have a rapid recovery, so that we can do an early neurological examination. Next. Post-operative pain, we can give a local infiltration in that area where the shunting is done, and also we can supplement with paracetamol IV or per rectal. Small shorter acting opioids can be given, but only under observation, because these patients are usually neonates or infants. They have a tendency to go into respiratory depression. And for post-operative monitoring, hemodynamics and other vitals should be monitored very closely, and the respiratory support need to be given in preterm infants. Next. To summarize the hydrocephalus, proper preoperative assessment is very important. That is anticipation of problems, and complete preparedness is important. And we need to identify the signs of raised ICP, difficult airway and associated comorbidities. So what should be our goal? Goal should be to maintain the cerebral perfusion pressure, that is to avoid any rise in ICP or fall in mean arterial pressure. So therefore we should avoid hypercarbia and hypoxia. Also our goal should be to prevent hypothermia and maintain volume, electrolyte and glucose level. In the post-operative care, early recovery is very important and extubation. Vital monitoring need to be done and pain control is very important. All this will help us in doing a good neurological examination post-operatively. Next. Coming on the meningomyelocele. So next, the meningomyelocele, what is the pathophysiology? There is, during the immunological stage, there's a defect in the neural tube. So what happens usually, the neural tube closes by 28 days of gestation. But in meningomyelocele, there is this neuration is defected. Next. Can be the neural tube defect can be classified in four types of neural tube defects are seen, like anencephaly, spina bifida cystica, and spina bifida occulta. So in anencephaly, the brain and skull is poorly developed. Okay? And in encephalocele, what happens is that because of the neural tube defect, the brain herniates through the cranial defects. And in the spinal bifida cystica, it can be a meningomyelocele or meningomyelocele. In meningocele, there is the herniation of the meninges through the absent vertebral column, through the midline. Okay, and in meningomyelocele, there is herniation of meninges. Along with meninges, there is a herniation of neural tissue in this. And then the fourth type is spina bifida occulta. Occulta is meaning is hidden. Occulta is hidden. So in this, there is a defect, but from outside, it will look like normal because it is covered with a normal skin. So usually these spina bifida occulta, they clinical presentation usually there's a small dimple or there will be tuft of hair. Usually they are not, they don't have any associated lesion. Next. So in this picture, the A is meningocele. Here we can see only the neural, the neural tissue is herniating. Meninges only herniating, whereas only the meninges is herniating. Whereas in the B, it is meningomyelocele. Here we can see the spinal cord. It's also coming out. Okay, so neural tissue is also herniating. And this is a picture of a child. Okay, coming on encephalocele. In the first picture, it is at the occipital region, so it is occipital encephalocele. And the second picture, the encephalocele is on the frontal region. Next, here the encephalocele is on the occipital region, and here it is in the frontal region. Next. Many neural tube defects have a very strong genetic connection. It is seen more in a female than in male, and it is seen more in Caucasians and Black. And parental consanguinity is one of the important factors. It is also can be seen with patient or mothers with folic acid deficiencies. And also when the mother takes some drugs like valproate or carbamazepine, in that case also the child takes birth with these defects. And also it is very commonly seen in the lower socioeconomic groups. Next. So the pathophysiology, it can manifest with either neurological symptoms. They can be motor or sensory deficit. So the symptoms can be related to the brainstem dysfunction or raised ICP. Okay. So brainstem dysfunction may patient might present with stridor, apnea, altered breathing pattern, repeated aspiration, so leading to aspiration pneumonia or some lack of coordination in the limbs, spasticity. And also raised in ICP, the sign and symptoms of raised ICP will be there, can be there, like headache, lethargy, vomiting, ophthalmic features like ophthalmoplegia. Next. So these neural tube defect, they eventually, what happens is that if they may burst, like, there may be leakage of the CSF from the defect itself. And also, since the defect is outside the skin, there are high chances of having infections there. And how do we diagnose them? So it can be diagnosed in the antenatal phase itself. There will be increase in the acetylcholine esterase and alpha fetoprotein in the maternal serum and in amniotic fluid in the second trimester. Also, when we do a prenatal ultrasound, then also we can diagnose the neural tube defects. The treatment usually comprises of surgery. The surgery can be done in vitro nowadays and can be done after the delivery, after the birth of the child. Since the time of the closure of this defect, we have seen like the studies shows that early closure is not associated with any increase in neurological improvement. So it can be, but it is preferred, the surgery is preferred to be done within 24 hours of birth, since the longer we keep it, the more chances of infections are more there. Next. Anesthetic considerations. Next. Again, the age related, since these surgeries are done at the neonatal age and infancy, so all the concerns related to this age group, neonatal and pediatric age group, need to be kept in mind. Then because of the meningomyelocele itself and during the surgeries. Next. The age related, like the airway, it is a difficult airway. They are more prone for hypothermia and they are more prone for blood loss and fluid shifts. Second. Next. So coming on to the pathology itself, that is the meningomyelocele, we can have difficulty in while positioning for intubation, and also while positioning for intubation, since depending on the level where it is there, what type of meningomyelocele it is. For example, in this picture, we can see a lumbar position mein, and there is one meningomyelocele. So the intubation is done can be done in first photo is showing the semi-lateral position, or a donut or a folded towel. A donut can be placed below the meningomyelocele defect, the tissue, and the child can be put on two big wedges like shown here, so that there is no pressure on the defect. Next. So in the cervicothoracic meningomyelocele, it is associated with high chances of postural hypertension, and in the frontal type of encaphalocele, there is associated airway obstruction because of the presentation of the encaphalocele, the location of the encaphalocele. They are also associated with comorbidities, many other congenital abnormalities. Because of these defects, they might have CNS lesions like motor deficit, and also they are associated with other congenital anomalies like Arnold-Chiari syndrome. They can have features of raised ICP. These defects are very sensitive to latex. So while examining these children, while examining this defect, we have to wear a latex-free gloves. Next. Now coming on to the anesthetic concerns related to the surgery. First of all, the surgery is done in a prone position. So for prone position, all the concern related to the prone position, we need to be very careful regarding. We need to take care of that. Like when we position, a gentle positioning need to be done. and all the paddings need to be done on all the pressure points. Also the child need to be covered properly, and the position of the AT tube, the right placement of the AT tube need to be confirmed after positioning the patient. The blood loss, it is because of the surgery, it is very difficult to see, to actually calculate the blood loss and the fluid loss in these type of surgeries, because most of the blood, it gets absorbed in the linen itself. So the calculation of blood loss and the fluid loss gets very difficult. So we need to we need to be very cautious regarding that part. Also, there is increase in the ICP because of the shift in the, because it's a spine surgery, because of the shift in the CSF dynamics. Next. So how can we give anesthesia? Next. As I told before, we need to take a detailed history pre-anesthetic in the pre-anesthetic evaluation. They are associated with, these defects are associated in siblings also, so we need to take that history. And examination, coming on the examination, we need to see detailed examination need to be done using a latex free gloves, where we have to see the defect, the site of the defect, where it is, the size of the defect, what is the shape, and if there any CSF is leaking or not. And also along with this, we need to see the curvature of the spine. We need to palpate the curvature of the spine also. Next. Detailed neurological examination need to be done to rule out any motor or sensory deficit in these patients. Cranial nerve involvement is also very common in these patients. Airway examination can be, these condition can be associated with other congenital anomalies. They can also have associated with facial clefts, very commonly associated with Arnold-Chiari syndrome. So they might be having, the child might present with stridor or with apneic episodes. Next. We need to rule out other congenital anomalies like kidney enlargement or absent kidney, club float, hip dislocation, cardiomegaly. So before coming to the OTA, we need to investigate the child. Like we need to get a complete CBC done, hemogram done, urine routine microscopy, blood grouping is very important. Also chest X-rays to see if the patient is already having an infection. So a chest X-ray need to be done to see any pulmonary complication, pulmonary involvement. Also CT and MRI of the brain if needed. Next. So pre-medication means, since most of the patients are neonates, and doing this, insulatics are usually avoided and not required. Anti-Salagog need to be done, need to be given like by injection atropine, or we can give glycopyrrolate, because we are going to place the patient in prone position. And pre-operatively nerve stimulations can be done in the patient if the surgeon is going to do a nerve study, a nerve stimulation test intraoperatively. So pre-operatively a nerve stimulation test need to be done before we give any relaxant, muscle relaxant. It need to be done. So for induction, we can use IV or inhalation agent. Relaxant may succinylcholine can be used if no signs of ICP is present, but usually we avoid succinylcholine in these patients. So non-depolarizing muscle relaxants can be used. If the child is big, we always cannulate before cannulating. We should use amla and then cannulate. Next. Again, maintenance can be done with inhalation agent and giving short-acting narcotics, and also short-acting non-depolarizing.
Sashmita, please wind up fast because we have to do a question-answer session also.
Okay, ma'am. Okay, ma'am. Some surgeons, they do during interop, they do nerve stimulation test. So the timing of the muscle relaxant has to be very carefully titratedly given to be done, so that when they do a nerve stimulation study, the patient should be should be out of the effects of the muscle relaxant. So the timing of the muscle relaxant, we need to be very careful about that. The ventilation is controlled, then fluid we can give RL or NS with 1 to 2% of dextrose, and the blood need to be replaced with blood. Next. For intraoperative monitoring, all the standard ASA monitoring, precordial stethoscope we can use to continuously assess the hemodynamics of the patient. And blood loss needs to be assessed properly. For post-operative pain, we can give through IV or per rectal NSAIDs can be used if not contraindicated. Next. To summarize, proper preoperative assessment, same anticipation of problems and complete preparedness is very important. Identify the position of the MMC, where it is the site of the MMC is important. Difficult airway and associated comorbidity needs to be assessed properly. So the goal should be to position the patient carefully, prone positioning, avoid any kind of hypercarbial hypoxia, prevent hypothermia, and maintain good volume and electrolyte and glucose level. So in post-operative care, again, early recovery and extubation plays a very important role. The vital monitors should be monitored. The vitals should be monitored regularly, and pain control should be apt in the post-operative period so that a neurological examination can be done easily.
Thank you, Dr. Sashmita. One very usual question asked in exam is, what is the name of Indian who made the shunt? So many examiners are fond of that question. So Upadhyay shunt is very, is the answer to be given here. And I think as we are time is too much, we should move on to questions. There is one question. This skin that is to you, Dr. Harshini.
Yes.
Skin temperature is what we monitor in units, usually being done in the regional and sedation. So usually, how is the skin temperature interpreted, and which is the ideal part in the skin to put the probe?
So the ideal part to put the skin temperature probe would be under the axilla or in the right hypochondrium. If we are using the axillary skin temperature probe, we should be make sure that the limb is adducted. Only then we can use an axillary probe. Otherwise, we can use the right hypochondrium because
hypochondrium is rarely available. So axilla is the right place, and how to interpret it?
The difference between peripheral and core temperature of 0.5 to 1 degree centigrade should be taken into consideration. So to know the core temperature, you can add 0.5 to 1 degree centigrade for whatever the peripheral temperature that you get.
So, okay. Then another question is, this can we give spinal in these patients for hernia repair if they come as preterm, less than 40 weeks? This is for you, Dr. Preeti.
Actually, books recommend spinal for the neonates, even preterm neonates, because they are more prone to postoperative apnea. And they say that the hemodynamic alterations are minimal, and the bradycardia is also not there in neonates because the parasympathetic system vagal tone is not so much developed. So it is actually recommended by the books, but I can't say because I don't have clinical practical experience regarding the same.
Another question is inhalational induction and then IV line. What do you practice?
We prefer to place IV access whenever possible. The child has received pre-medication, especially we use midazolam, oral midazolam, and then the child becomes cooperative enough most of the times to get the IV access. If we are not able to get IV access, child is uncooperative or this thing, then we do an inhalational induction in the OT and then we place an IV line.
Madam, sorry to intervene. See, if you are inducing with inhalation induction just to secure an IV line, if suppose a problem happens, how will you manage? Or what is your expertise in that? That is, whether you have not seen any problem because a child undergoes laryngospasm and bronchospasm very easily, whatever may be the thing. In a crying child with an inhalation induction just to secure an IV line, if suppose problem happens, how will you manage?
So there is basically two things which we keep in mind while we doing inhalational induction. Number one, we are not doing positive pressure ventilation. It is the spontaneous breath which the patient is taking. We just maintain the patency of the airway until the IV line is placed. We don't give any positive pressure ventilation. The child is absolutely on spontaneous ventilation. And also we avoid using nitrous oxide because although they say with nitrous oxide, the inhalation induction is faster, but then if there is any desaturation, that becomes faster with nitrous oxide. So we do it with air. And so with sevoflurane, because it is very well accepted by the children, so chances of laryngospasm or complication is less when we are not doing positive pressure ventilation. We keep the child on spontaneous ventilation till the child becomes little sedated.
I'm worried, madam. The youngsters.
Sir, I think, sir, can I say something, sir?
Yeah, you have to, ma'am.
Yeah. Sir, actually, your question is very valid, and we have to be very careful when we are giving child on inhalational for without an IV line till we secure an IV line, because if anything happens at that point of time, we will not be able to do anything. But most of the time, if child is cooperative, we may take IV line, but that may not be the situation in most many scenarios. So the thing is that we have to be first, we have to understand that this is a difficult situation, and we have to be careful. And there are two things: either step up and step down. So if you are doing step down, like if you are a careful person, you will probably go for step up, like gradually increasing the inhalational concentration. And most of the people like to do step down because children are usually uncooperative, they are crying and all that. In that case, come down very fast. Like you can, for few breaths, you can like keep on high inhalational, but decrease the concentration quite fast. And when we decrease the concentration and we keep the patient on spontaneous, so when the more inhalational agent goes, the child's respiration becomes depressed. So the child stop, like the breathing is less, inhalational going inside is less. So you end up having less problems. And another this error which people do is they do wrong induction, and then the moment child become apneic, they put an airway which is in light plane, and then there are chances of laryngospasm, and you don't have an IV line to deal with the thing. So be very careful. And we train our children, like students, like that, and we do not encounter problems mostly.
What is your opinion about IM ketamine just to secure IV line?
Sir, the thing is that we have better pre-medications now. Like midazolam is a very safe pre-medication, but whatever pre-medication we are giving, we have to be careful and we have to observe the child. And with midazolam, we are able to secure IV line quite in most of the cases. And then this now clonidine and dexmed has also come in pre-medication. So ketamine was used to be given earlier, but now it doesn't have much place. Can be used if we don't have other drugs, but midazolam, even IVB, we mix in juices and all, and we give, which is very safe.
So one thing I want to add here, that IM ketamine is a kind of invasive thing. We are giving an injection that we used to do many years back. Now we have this midazolam, which is IV preparation. We are mixing with the dextrose, which is available in the OT, and the child accepts it very well and becomes cooperative. That is an oral thing. With little 5 to 10 ml of dextrose, we mix the dose and give it to the children.
No, this is to tolerate the pain of injection. See, to secure IV line, IM injection is given. That's all. To secure, because even the apneic incidence will be less than this inhalation induction. What I am worried for people who are experienced and who has the expertise like you can do. Can a listener, just a finished MD finished person who is entering into the practice, he should be very careful before inducing the child with the inhalation just to secure IV line.
Absolutely.
Just to secure IV line. If practice is gone.
Yes, the person has to be careful. But sir, midazolam is a very good pre-medication. It usually allows like CT scan and all. In CT scan and all, we are regularly securing IV line with midazolam.
Oral midazolam.
Oral midazolam as a pre-medication. And Is there any other question, sir? I can't see
Yes,
anything
yes.
in the chat box.
Critical temperature. Critical temperature is mentioned as 1 degree centigrade. So what does it really mean? What is 1 degree centigrade means what?
Sir, critical temperature, by the definition, if we see, it is the temperature below which an unanesthetic person cannot
Yes,
maintain
correct. But
very cool
that
temperature.
means 1 degree means what? See,
Up to that temperature, adult can maintain by using
madam,
all the thermoregulatory mechanisms.
how a child, as an adult can maintain up to 1 degree centigrade? That's what I'm asking, because you were saying for neonate and pediatric 28 to 32. But how
See,
an adult can withstand 1 degree centigrade?
1
What
degree is not absolute value, Harshini.
It
Can
is
you
not.
just clarify that?
she has mentioned that her slide is showing like that. It is not the difference, it is absolute temperature she mentioned. 28 to 32 and 1 degree centigrade. 1 degree is even in Delhi, where the climate is 8 degree centigrade, people are suffering. 5 degree, 1 degree, how they will maintain?
Sir, that is, I mean to say, the critical temperature is till that temperature by using all the thermoregulatory measures can maintain core temperature still.
That
So
I'm
that
1
doesn't
degree,
mean
asking.
that we
1
Your
should
degree.
take
slide
the
is
adult
saying, then
to
moderator has to
the
answer. Your slide is saying like that, till 1 degree centigrade, the adult can manage the temperature. I'm asking at the 1 degree centigrade, whether the adult will be alive or what exactly he will, how will you
That is
decrease
a
the temperature?
hypothetical and theoretical thing.
Ah.
1
Yes.
degree is not at all practical.
Sir,
Yes.
And,
actually, the book says since PG time we are reading that for adults it is 1 degree. That means below 1 degree, an adult cannot maintain its core temperature by any means.
Yes.
And
yeah, but in clinical practice, that 1 degree doesn't have any meaning.
It's right.
Yes.
No,
It
ma'am,
is just
it
a
is just for
hypothetical and theoretical thing.
absolutely,
Basically.
absolutely. It is seems a very theoretical concept, but if we read the text, maybe they are studies and they say that this, but definitely 1 degree Celsius is too less to
Madam,
maintain.
I request, that is the reason why I have given the guidelines. Please, we need not talk about any research paper or research
So this
hypothesis.
is not research. This is
Yeah,
mentioned
this
in
is,
the
no,
book.
it is
This is
mentioned,
Really
which
mentioned in the
book,
book.
madam, which book it is
Miller
mentioned?
says, Miller said.
1 degree.
Yeah, see, Dr. Preeti, it is mentioned in the book, but it doesn't have any practical
1
use.
degree.
It doesn't have any practical use,
It is for
basically.
comparison. For with the pediatric age group, we always read it only for comparison. Basically, definition of critical temperature is important. We may not dwell into the absolute degree of temperature. Basically, definition of critical temperature is important.
Sir, when we say critical temperature is 1 degree centigrade, I don't mean to say that we have to allow the adult to go till that temperature. We have to prevent at any cost any temperature which
That is what I am
generates.
saying. Madam, a listener will interpret. If you say critical temperature is 1 degree, below which up to that temperature, the patient can maintain the thermoregulation, means what? Up to 1 degree they will allow. Even that's what you say, 28 degree, 32 degree neonate and the pediatric, you are not supposed to allow it to fall because that is the critical temperature.
That
So
range is very narrow, sir. We cannot go below that
we need
range. It
not
is very
brood over
narrow.
that. Madam, one more question is.
And severe hypothermia is also very high
Yes.
temperature, not very less.
Because they say 18 degree centigrade ventricular fibrillation occurs. Even 25
That's what.
degree only we are cooling in
Even for
CPD.
severe hypothermia, temperature is very high.
Can we sedate if the baby is irritable and crying incessantly? One question is there. Last but one. Can we, Dr. Muthukumar Rajagopalan, can we sedate if the baby is irritable and crying incessantly?
Sir, I didn't get the question, sir. Can we sedate if the baby is
irritable and crying, incessant cry? That is uncooperative child.
That is in uncooperative is okay, but what is the situation if it is a pre-op baby or post-op baby?
Pre-op only is asking. Yeah, pre-op, post-op anyway.
He
has not mentioned.
The situation
He has not mentioned pre-op or post-op.
that situation has to be there. Pre-operatively, obviously, we have all talked about. Dr. Preeti, you want to answer that?
Ma'am, it is basically the situation we have to first find out what is the reason of being irritable and crying. What is the pathology because of which it's not that child is having pain or is he hungry. So we have to see all the situation and then only decide that whether we have to sedate the child or not. But basically sedation is pre-medication, but only if the situation allows.
Also, I
Absolutely,
add in this
absolutely.
that pre-medication, we usually avoid pre-medication in neonates. If like cases like this meningomyelocele we are talking about. So, but depending on the situation, as Dr. Preeti said, and the condition, the bigger child can be sedated depending on the situation.
Yeah, definitely. The child can be sedated, but sedation is not an answer if the reason is something else that might be derogatory, basically.
No more questions, madam.
Thank you, sir. Over to you,
Madam,
sir.
you can have a wind up discussion remarks if you want to say, or else we will go for the flying session.
So yeah, I mean, already we are we have overshooting the time only. I would like to say one thing, sir. Allow me to say one or two sentences. Another thing examiner is interested in knowing is that you know how much doses you will give. Those things you should not be, that has to be correct, especially in small babies. And another thing is examiner wants to know whether you will be able to tackle if there is any problem. Like child goes into laryngospasm, child desaturated. So these are very common questions, and you have to know how to manage that. And what is the size you predicted, and you put the tube, is it the right size, is it oversized, how would you know? So you have to have minimal leak at 20 centimeter of water. These kind of questions you get in exam in practical this thing. So those things you have to come prepared. Thank you, sir. Over to you, sir.
Thank you very much, madam. As moderator madam pointed out, we are restricting our discussion as we are overshooting the time. It is beyond 8. Now, formal vote of thanks. So now I thank Dr. Harshini for her elaborate description on thermoregulation. She was very cool and kept us also very cool. And it was followed by Dr. Preeti ma'am, who has given her expertise in managing difficult cases, that too with ASD coming for inguinal hernia. Even clarifications were sought on that. And Dr. Sashmita Das, assistant professor, she has also given an elaborate description. And it was very meticulously moderated by Director Professor Lady Hardinge Medical College, Dr. Anshu Gupat, who was instrumental in arranging this webinar. And Puthukkottai, it is in the south territory, and exactly Delhi is 3,800 kilometers away. And those people, we are fortunate to have you as our faculty, because the youngsters all over the country will be benefited by your lecture. That too, pediatric anesthesia is practiced in every corner. It is not like cardiac or neuro where it is practiced in specialized centers. So we expect the attendance also to be more. Tomorrow we will know how many people attended live. So we will keep it in YouTube also. The recording link will be sent to you. So the postgraduates will be benefited by that YouTube channel. Once again, I thank you very much, and also the Clarinet for their technical help in providing this platform for us. So over to Clarinet for the concluding remarks and closure of the webinar.
Yes, thank you so much everyone for joining this session. Clarinet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session for today. Thank you so much.